So thank you for the introduction. I hope I'm not too loud. Yeah, my talk will be focused on advanced metabolic brain perfusion parameters in the setting of radionecrosis versus tumor recurrence, and then afterwards a short outlook what may be relevant and what may be interesting in the setting of low-grade gliomas. For the structure, I will start with a quick background, some short information, then go quickly through the current science for radionecrosis versus recurrent tumor or recurrent glioblastoma. Then show you some new imaging techniques with regard to perfusion. Afterwards, some exemplary cases, some study results, but I have to admit these are preliminary results because as we are doing a big multicentric study, I'm not ready with the full results yet. And then, I'll conclude with an outlook. When we look back at the beginnings of MRI perfusion, then they already did back in the beginning of the 19th, so we have 35 years of experience with MRI perfusion, and already in 1998 there were the first papers about samples of MRI perfusion with regard to brain tumors or glioblastomas, so quite a while. And 14 years later, so in 2012, I found an article that stated that MRI perfusion is integral or plays an integral role. And if you read the article 5 sentence later, there is why is optimization of perfusion essential? So quite debatable and no real recommendation for clinical routine. Even before the era of MRI, we radiologists or neuroradiologists tried to find something to monitor disease and to see early recurrence of glioblastoma. And initially, there were some people that tried to implement criteria that would be beneficial in order for a standardized report that may be of use and could be useful to determine is this recurrent tumor or not. In 2010, then there were the RANO criteria implemented, which were then revised several times afterwards, so with regard to immunotherapy. And then RANO 2.0 was implemented 2023. But although we have these criteria, which are quite painful to adapt in clinical routine, there is still, it's still a problem to really see if this recurrent tumor or not. And if you look at the guidelines and read them, then it says advanced imaging techniques such as, and there is also perfusion named. They say that they are quite interesting, they may be good, but so far data is lacking that we do not incorporate them in the RANO criteria. So perfusion does not really play a role if you adapt this criteria in clinical routine. And they are most only focus on enhancement in the T1 post-guard and T2 flare progression. So no perfusion here. When we talk about recurrent tumor or radiation necrosis or pseudoprogression, then it's important to know at least some background definition, because pseudoprogression is 0 to 6 months after radiochemotherapy, and radiation necrosis is 6 months after, and then there is no clear limit, but most often it's between 6 months and 24 months after radiochemotherapy. And whereas pseudoprogression can be monitored clinically, because most often people they increase or improve, whereas radiation necrosis is harder to determine because people deteriorate no matter if there is radiation necrosis or there is recurrent tumor. You can try to discriminate, because sometimes recurrent tumor, they deteriorate faster, but it's not that easy. In general, if we look at glioblastoma, CBV is increased. And in general, if we look at pseudoprogression or radiation necrosis, CBV is decreased. And I say in general because if you look at literature, it is, you read from perfusion is useless to it's the holy grail and 100% sensitivity. So there is quite a debate. And the most important thing is that many papers state specific thresholds. They do not really exist because sometimes you read 2.0, 2.6, so there are various thresholds, and they're not that easy to implement because the radiation necrosis is often not a homogeneous process, so or the tumor progression. So you find radiation necrosis adjacent to tumor progression, and thus it's not that easy to discriminate between them. For pseudoprogression, there could already be, or it could already be shown that new perfusion algorithms are beneficial, so that they can help and improve the sensitivity in the first 6 months, so pseudoprogression versus recurrent tumor. But of great interest is also the phase afterwards, because this is the one that is clinically hard to monitor. Current diagnostic signs are, let's say, debatable. I took some imaging examples from literature because I do not want to make myself offendable, because I think that even though you have the impression of, let's say, this is a cut green pepper sign, 1 of 3 would say this is no cut green pepper. So it's not that easy. And although there are papers that show nice diffusion restrictions, personally I've never seen a so beautiful central diffusion restriction in radiation necrosis in my whole career. So they are not that easy to implement. And then, as already said, in general, CBV reduction. Now we have some new perfusion algorithms, and you already heard many of them. With regard to my talk, I'll mainly focus on CBV, so the new CBVs, a new calculated CBV with a new algorithm, and also at some points CMRO2, as this is also an interesting parameter in the setting of brain tumor recurrence. Just some exemplary cases to give you an impression. This is a patient that had glioblastoma, underwent resection, radiochemotherapy, and then afterwards developed a contrast-enhancing lesion adjacent to the trigonum of the left ventricle. And if you look at the new perfusion maps, you can clearly, sorry, this is a CBV, you can clearly see that in the location of the contrast-enhancing lesion, there is hyperperfusion. So if we trust perfusion, we would say, yes, this is recurrent tumor. And what's interesting is to see there are 2 aspects. One aspect is, if we have these new algorithms, could they be better than the currently used ones? And not only be better in with regard to it may look more beautiful or be a little bit prettier image, but just a better outcome because we see the tumor even earlier, or perhaps we see hypervascularization where with the standard techniques we wouldn't see anything. And this is the standard CBV that we calculated with our current software we used prior to Circa. So you would state it's no hyperperfusion. And to go one step further, if you look at the prior image, because to be honest, we saw this and we did not see hyperperfusion at that time, but it still looked ugly, so we did not trust our perfusion map and still stated this is highly suspicious. So we did a fast follow-up. We do then them about 6 weeks after our first exam. So if we go back 6 weeks in August 2020, we could already see the hyperperfusion. You can argue that it was a little bit smaller than it was in September 2020, but although we did not even see it with our standard maps in September, we could have seen it with the new maps already in August. So this may clearly be beneficial. And a further exemplary case, so this is a patient that you hope you can see. There is some cystic enhancing lesion, so this was the glioblastoma, then underwent resection and follow-up examinations. And throughout our follow-ups, we can see that there is a progressive enhancing lesion on the trigonum of the right ventricle. And to be honest, it looks very similar to the lesion that we saw in the previous example. And when we now take a look at our perfusion maps, then even in CBV, then and also in CMRO2, there is no clear hyperperfusion in the lesion, and this was a histology-proven radiation necrosis. So these new parameters may be of help because they could raise sensitivity and maybe specificity. So as I already told you, we're performing a multicentric study with a big data set, so I cannot show you the final results, hopefully in the next talk, but you can see this as a teaser. So when we went through half of our cases at our single center study, we did a preliminary statistics, and so as you have to exclude every patient without histology, so proven histology, every patient that is in between the process of pseudo-progression, you have to exclude many of them. So from our single center, we result in about 80 to 90 patients for the last 8 years. And in these 48 patients, we could show that with our standard CBV, we had a sensitivity of 75%. So yeah, okay, but not that great. And when we look at CBV maps of the new techniques, then we could significantly raise our specificity to about 92%. So we're going next to PET sensitivity, which may be of interest because you do not have to change anything. So you just do your normal perfusion and perhaps you can raise your sensitivity. And more interesting, when you look if you could have seen something in the prior images. So we normally do them every 3 months, the control, sometimes 6, if it's suspicious, 6 weeks. And if you look at this, in 41 patients, we had 6 cases, and you have to dismiss the 4 radiation necrosis. So in 36 recurrent glioblastomas, you could have seen the hyperperfusion already in the prior image. So this may be of great use because as we want to reoperate patients as early as possible, if we think that there is recurrent tumor, the patients can profit. So as an outlook, these are promising results for sure, but as I said, this is only a teaser as we need multiple blinded readers, multiple centers, because most often if you look at literature, the most prominent aspect is that this could be useful, but everyone does it somehow different and there is no standard. So you need multicentric studies in order to see that we can eliminate this aspect as much as possible. And what's also an interesting outlook is the performance of perfusion in low-grade gliomas, because this is an interesting case. This was a histology-proven low-grade glioma, and if you look at perfusion imaging, so the maps on the right-hand side, then you see that there is a clear hyperperfusion in the basal ganglia, although there was no contrast enhancement in the T1 post-GAD, and it looks really ugly in the perfusion. So this will be an interesting aspect with regard to therapy monitoring, perhaps also monitoring of de-differentiation and also guidance of biopsies if you cannot resect the tumor to ensure that you are on the right spot when you try to make your histology. Thank you for your attention.
Thank you very much for a exciting talk. Do we have questions from the audience? No. Oh,
Thank you so much. I'm sorry, I'm coming from the surgical part, so I have to ask this. As a surgeon, I ask myself, what do I need this for? You understand? Because does that change my indication for operation? And if we do see a lesion, we will do follow-up anyways, with or without the MR perfusion.
No, so
I'm not trying to be critical. I'm just trying to understand the value.
But it's important to be critical. No, I think the most important aspect is that we see small lesions, that we monitor regularly and see them grow. And when it's big enough, we say, okay, this is so big, this must be recurrent tumor. But then we lose time. So the outlook would be that maybe we have a technique that we will be so confident and determine that although it's a 5 millimeter lesion, this must be recurrent glioblastoma, or there are high chances, then maybe you operate earlier.
But that's exactly what I'm trying to say.
Yeah.
Like, you had some cases yesterday, and there were some little lesions. You know, I looked at it and I'm thinking, okay, can I say this is recurrent or not? This is a patient. This is a person. So regardless of MR perfusion, I would do a follow-up because I can't be certain. So I would.
So far not. But when we have data, therefore, perhaps we can.
I'm just trying to understand.
Yeah.
Sorry.
other questions? Yep, there's one here.
Do you have any correlation with the fat PET?
No. We do not perform them regularly on every patient, and this is retrospective. This would be interesting in a prospective study with defined setups of defined timeline, but this is just retrospective.
Thank you so much for these interesting insights. It's, as you said, it's a group of patients where there are just some huge dilemmas of what is it that we're looking at and how can we best turn out that knowledge into better patient treatment. Excited to see the follow-up of your presentation. Thank you so much.